Welcome to chapter 9. This is my chapter. What I mean is, as a registered nurse, the law applies to me in my daily career. So I'm going to do my best. I'm going to try really hard to keep this video quick. This chapter alone, I could spend weeks teaching you all and sharing the stories and sharing what I've experienced in a 24-year career as a nurse in Raleigh, North Carolina. I have floated to rural hospitals in Franklin County, Wilson County, Johnston County, and worked also. And the stories are different because working as a nurse at a level 1 trauma center in a major city is very different compared to working in rural county level hospitals. But anyway, like I said, you're welcome to email me and outreach me if you want any extra stories or information. But I could spend hours teaching this chapter and talking about the scope of nursing and how we delineate from that accidentally or how it happens intentionally and the ramifications. And again, look, I'm going to try to make this quick. Okay. All right, so let me use this slide as my guide. Learning objectives are listed here. Please take the time to read the quotes from the unknown authors on page 165, especially if you're thinking about becoming a nurse or just want to know a little bit more about the field of nursing. Read those quotes. It's a great little introduction. Okay, so learning objectives are listed here, and they are on page 166 of the book. Scope of practice is a big deal in healthcare, especially with nurses, because we are the leading number of employees in healthcare. It is what it is. We surpass the number of physicians. We surpass the number of technicians. The nurses are the heart of healthcare. We have our own scope of practice. If we exceed our scope that is listed, that's a violation, and there will be disciplinary action that occurs. And each scope is different per state. There's a nursing act for each state. So we have federal guidelines across the U.S., but each state has their own specifications for what our scope of practice can be. And also, if you are an associate degree nurse or a bachelor degree nurse, MSN nurse, there's different things that come along with that as far as ability and where you can work. Also, different hospitals. I may have my master's in nursing, and at one hospital I can do this and another hospital doesn't recognize it. So it's the nurse's responsibility to know what's within their scope of practice. Maybe at one of the hospitals I can get checked off to intubate, where at the hospital right down the road that's not something within my scope of practice. So very important to know that, because a lot of liability falls within that. Nursing diagnosis, you can read about that on page 166. I'm not going to go into that for sake of time. Nursing licensure, yes, each state has a nursing license requirement. So not only do we go to school and complete a very intense, hard program that's very similar to medical school. The courses do not differ all that much, the core courses themselves. You also have to get a license within the state. Some states allow for multiple license. So like, for example, North Carolina is a compact state. I could actually work as a nurse in other states, but there are states across the country that are not compact. And so if I were to move, I'm just going to use this as an example, from Wyoming to Oklahoma, if they're not compact, then I have to repeat an exam to practice as a nurse in Oklahoma. This is continuing, and you're going to read a lot of this in the book about the waiver, endorsement, examination. Then we get into suspension, and that is a real thing that happens actually as a registered nurse. We get a bulletin every month, and the very back page of each bulletin is there's nurses' names and how and why they got their license revoked or suspended, etc. It's real. It does, and it happens frequently. Sometimes you get them back, sometimes you do not, depending on what the offense was. Practicing without a license, absolutely not. You cannot do that. When there is fraudulent activity involved with that, or somebody posing as a nurse, you go to jail for that. That's a big deal. So classifications of nurse staffs, or did I say that right? Of nursing staff. I prefer nursing staff. So there are nurse managers. Obviously, as a career, nurses just don't go around making major unit decisions on their own. There is somebody governing them, and it's nurse managers. You wouldn't want a CEO who maybe has a background in business managing nurses. It truly needs to be a nurse manager for so many reasons. They need to know what we do. Registered nurse, that is someone that is they graduate from an accredited nursing program, of course. Then we pass a national licensing exam, and we also have to keep up our continuing education. You have to do, right now I think it's 30 hours of continuing education every 2 years. So when we renew our license, we have to submit that information to stay competent and remain competent in our profession. LPNs and LVNs, the book goes into this too. These are not registered nurses. So registered nurses would be a little higher with more scope and more ability to do things. The LPN, the LVN is just a step down. Still very important. LPNs, LVNs do not work in hospitals. That you have to have a registered nurse. LVNs and LPNs are usually found within nursing homes, maybe some dialysis centers, but hospitals, at least the hospital I work for, we're a level 1 trauma center and we're magnet certified. We do not hire LPN and LVNs. Float nurse, this is somebody who literally floats around to different units, different hospitals, maybe even different counties and work. An agency nurse, this is very popular in COVID, where we had so many traveling nurses. This is also what an agency nurse is. It's where the hospital says, hey, we need extra help, and you hire an agency to staff. So they may not be necessarily hospital-based nursing employees, but they're from an agency, like a temp agency, very much so. Like they do that in the dental world, they do it in the corporate world, where you have an interim person in the position. Special duty nurse, this is somebody that is hired by a family to perform specific care for a loved one. And the scenarios that this occurs in is somebody cannot afford home health. Not home health. Rehab or like rehabilitation. I'm not referring to substance abuse rehab. I'm referring to nursing rehabilitation, which is very, very expensive. You would hire a special duty nurse to come in your home or that person's home and take care of them. All right, so traveling nurse is a lot like an agency nurse. Student nurse, every hospital has these. I just said every hospital very confidently. Most hospitals in our area are teaching hospitals to some to some point. You have to learn somewhere. If there's a local community college or university that has a nursing program, most likely the hospitals in the area will take students. All right, so then you become a nurse, and the next step is advanced practice nurse. This role extends beyond the hospital ward. I haven't heard that in a long time. That's what they used to be called. We now call them units. Anyway, okay. So nurse practitioners is an advanced practice nurse. So they're already RNs, and they go further and get their master's degree, and they become providers. So they still work under a physician, but they can actually write prescription medicines. They can order tests and labs. That's not something I can do. I did not get my master's in nurse practitioner. I got my master's in education. You guys can read that. Clinical nurse specialist. So this is a nurse with advanced degree and experience in a clinical specialty. Certified nurse anesthetist, the same thing. This is an RN who went and got their master's degree in anesthesiology. Nurse midwife is a registered nurse who went further and got their master's in delivering babies. Midwifery is another word for it. Certified nursing assistant. So this is a person who goes to a local community college or a school and takes maybe a 3 to 6 week program. We, as a registered nurse, we supervise nursing assistants, and we need their help. It takes a lot of help to manage anywhere from 6 to 10, sometimes 12 patients. Registered nurses cannot do it all. Between assessments, passing meds, changing dressings, putting in IVs, hanging drugs to give, emergency situations, we have to have nursing assistants to help us to get that whole load done. All right, so I've been flipping through the page too in the book. We are now on page 172. So many legal risks involved in being a nurse. So many. These type of things are drilled in our head during lectures when you're in your initial program and you're learning, and there are several questions about legality and liability on our our state examination, the NCLEX is what we take as nurses. This is real, and we're taught this from day one, the legal risk involved in nursing. I'm not going to read these to you. The book does an excellent job. I highlighted so many things about this, how you can fail and not do something right. But I have to say, most of this comes to you common sense wise if you look at your patient as your mother, brother, sister, uncle, father, as a loved one. Let's just summarize it that way, be inclusive. If you can look at your patients and view them as a loved one that you care immensely about, you can avoid most of this stuff. Do not go into healthcare, especially nursing, if you do not have a genuine passion and care for the human race. You will not succeed. You will find yourself in legal trouble with liability issues. And that's all I have to say about that. There's a lot of risk involved. You have to love what you do to become a nurse. Infections, this is a huge deal. Again, I'm not going to read all this to you. It is in the book, and the book is excellent. Delay in treatment is a huge deal. Failure to follow instructions, absolutely. You must report changes in patients' conditions, even when they're a good change, but definitely when it's a bad change and the patient's getting worse. You have to verify orders. If a doctor writes an order or calls on the telephone and gives you an order, you have to repeat it back to them. And if you cannot read that doctor's handwriting, you have to contact him or her and say, what did you mean by this? And each hospital has a different policy on how to correct that. Time and date with every documentation is important. We do not even give, in the recovery room, when you give a patient a blanket to keep them warm, you document that. That's how serious and particular that we are in nursing. Discharge. If a surgeon or a patient, doctor, radiologist, cardiologist, anybody gives you an order to discharge a patient, but your patient's blood pressure is way too high, you do not discharge that patient just because the doctor said to. You question it. You have to. It's your license at risk. Same thing with given medications. If a doctor orders a penicillin or an antibiotic that's twice the normal doses that you give, you don't just give it because it was written that way or called in that way. You question. You have to. So please read all these court cases and examples. It can happen. Some things are accidental. That whole love your patient and having a passion doesn't cover you for everything. You really do have to understand and keep up to date with what's expected of the scope and what courts are allowing, not allowing. And honestly, in all of my decades of being a nurse, I have been in a deposition, and I was right. I was the key witness, and we did everything right, and we won our court case against the defendant. But that process changes you. That's when you go to really documenting everything you do and making sure you've done everything, and you consult with a nurse leader, nurse manager, supervisor, charge nurse if you are in a situation that you don't understand or you need help with, because you don't want to land in court. You really, really do not. Oh, medication errors, very, very common, and it is very easy to happen. So if you are juggling 12 patients, take your time when it comes to medications. Identify your patient. Make sure it's even the right person. Make sure that, maybe you've given 1 Benadryl to 10 different patients that day, and all those Benadryls were pink in color, and then suddenly you arrive to Mr. Smith's room and his Benadryl is not pink, it's blue. Would you give it, or would you stop and wait, say, wait a second now, this is not what the other ones look like? And that's just an example. But Benadryl's always pink, just so you know. Okay, infections, yes, that's a huge thing. Negligence, you guys, the book is amazing. Okay, I'm going to keep going. Case 1A, the laceration, you can read that. The chapter ends on, there's a lot of cases here. And then review questions. Okay, so PowerPoint's pretty hefty, but the book really has the great information that I want you to review. And it ends with falls. And yes, nursing healthcare facilities, if a patient does fall, it really is neglect, because there's so many ways to prevent somebody from falling. It is ultimately the nurse's responsibility and the facility's responsibility to provide the equipment, the training, alert systems, and everything to prevent a patient from falling. So that is nursing law. 15 minutes is still long, but I'm telling you, I could talk to you about this for hours. So I'm going to stop talking now. If you guys have any questions or want any more information from me, just let me know.